Okay, right. So you've heard, I've been a consultant since 2005. I trained in the UK and subsequently did fellowship in Toronto, Canada, and Sydney, Australia. My interests were hip and knee pathology. I specialize primarily in hip and knee replacement surgery. I do some knee arthroscopy, and more recently robotic surgery and minimally invasive surgery. I work both in the NHS and in the private sector at the following hospitals. Now, we're having some technical difficulties because my slide's not advancing. Hold on one second. Why is that not advancing? Oh my goodness. Apology. I cannot even see the arrow to advance it. I don't know what's going on here. Right, here we go.
Sorry, you can use your cursor.
I'm okay. I think we've got there. So we passed that. You know, you heard that I was the first female of African Caribbean origin to become a consultant in the UK and the first woman in Europe to perform Mako robotic hip surgery. Apart from my clinical work, I am a medical examiner for the University of the West Indies for Trinidad and Tobago, and a surgical finals examiner for Imperial College here in London. I am very much interested in diversity. When I became a consultant in 2005, women made up 3% of the consultant body in the UK. And similar figures are found across the world. Currently, we're only up to 6%. But I'm happy to report that within the current batch of trainees, over 20%, just over 20% are now women. Now, my interest in diversity goes beyond gender and ethnicity, but also looking at aspects of neurodiversity in all different types of diversity. So those who are injured in some way and trying to facilitate them getting back into surgery. I'm also very interested in women's health. I think it's an area that's very much overlooked, and particularly with relation to hip pain, because during the perimenopausal or menopausal period, a lot of women do experience pain around the hip, often related to weak muscles in the pelvic floor. And so this is an area that I'm focused on. Now, what are the current advances? There are quite a number of advances taking place currently in joint replacement. Optimization of the patient, making sure they're best prepared to undergo the surgery and to recover adequately. Refining our surgical technique that will reduce tissue trauma, which will lead to reduced pain. We also want to look at our pain measures that we use in surgery to try and make sure patients' pain is adequate so they can mobilize satisfactorily and get home early. And because they're mobilizing, the risks associated with surgery, such as getting blood clots, etc., can be minimized. Also, by refining our technique, the length of surgery is reduced, and that reduces the exposure of the wound and therefore the risk of infection. We are always trying to improve our implants to make sure that they are as closely related to the normal anatomy as possible, and that the material used is very closely related to bone in terms of its elasticity, etc., to prevent any bone wasting that may take place or any fractures at the interface between the implant and the bone. We want to make sure that the prosthesis is such that the wearing, because that's what happens over time, when two surfaces are rubbing against each other or moving against each other, debris is created, and we want to reduce the amount of debris and the volume, not only the volume, but the size of the debris particles, because that's what leads to eventual loosening of the prosthesis, because the body recognizes that material as foreign, tries to engulf it and digest it, and in trying to do so, releases substances that lead to weakening of the bone. Orthobiologics is another area that's advancing. I'm not going to spend too much time on that. I can't cover everything in this short space of time. Infection detecting and prevention is critical. There's no point going through the whole joint replacement procedure if we're going to have patients get infection, which can often lead to further surgery. Often, if it's very severe or it's a virulent organism, it may require complete removal of the prosthesis and starting again. We want to we've recognized the importance of postoperative optimization. Optimization of patients is key prior to surgery as well as after surgery. And postoperatively, we focus more on the physiotherapy aspect of things, but physiotherapy is equally important preoperatively. And then there's some latest advancements in terms of robotic surgery, 3D printing, etc., which I'll touch on. So this is a very busy slide, but I'll summarize it. Patients' health is very important. And before they come to surgery, they need to be adequately optimized. And we know that there's a relationship between anemia and increased hospital stay, infection, as well as mortality. Ideally, for women, you want to get an HB above 13, and for men above 14. There are cases, of course, where if patients have chronic disorders where their hemoglobin is normally maintained at a lower level, and this will be decided on an individual case, but if possible, the hemoglobin should be normal. Because what we're trying to do is to avoid blood transfusions if necessary. And because there is going to be some blood loss, our techniques, we try to minimize that. It may mean that these patients may require transfusion, and that's what ultimately we want to prevent. There's an increased failure rate in implants when people are smokers, and so we try to encourage patients to stop smoking prior to surgery. It's good for their respiratory function, reduces the risk of chest infection, etc., as well as we know the free radicals that are produced from the smoking can also lead to loosening of the implant. Obesity, I think that's quite intuitive that if you're carrying excess load for over a long period of time, you're going to get increased wearing of your joints, so you're more predisposed to getting arthritis. And equally, there's increased stress on the implant, which may lead to early failure. So we want to try, before we get to the surgery, to try and get patients to reduce their weight. It's not always easy because, because you're in pain, you can't exercise. But if patients really need to try and do that as much as possible if they want to get the best outcome. And we know that if patients have underlying respiratory problems such as sleep apnea, then that increases their morbidity, mortality, the risk of getting pulmonary embolism, as well as wound problems. So all of these things need to be optimized before patients come to surgery. Patients also need to make sure that any medication that they're on, that's been, that's been sorted prior to surgery. And as part of our pre-assessment process, we spend a lot of time with patients looking at things like that. Also looking at the home environment, making sure that it's adequate for them to return home safely. Now, what patients don't often realize is that your preoperative range of motion is a great predictor of postoperative range of motion. Some patients come with very, very stiff knees. They expect to have a replacement and then to just regain full range of motion. All we're doing as surgeons is replacing the worn articular cartilage and underlying bone. We're not doing anything really to the soft tissue envelope. And if that's very constricted, then patients will still have that constriction afterwards. Often with arthritis, there are mechanical impingements to movement due to excess bone being formed. Of course, that will be removed during surgery. And so that in itself will lead to some increased range of motion. But mobilization of the soft tissues is equally important. And therefore, preoperative physiotherapy is key. Now, also, I spoke there specifically about the knee in terms of range of motion, but strengthening of the gluteal muscles around the hip will also lead to improved mobility and stability post-surgery. It's important that we set patients' expectations at the right level, and that's where adequate consenting of patients is key, where we discuss what their expectations are from surgery and be very honest about what it is that we can achieve post-operatively, so that we're both on the same page. That's the key. Now, in terms of wound closure, I normally close my wound with a suture, and there's some people who use clips. And because of that, the appearances of the wound may be different initially. When you use a suture material, I use that because I think it gives a better appearance of the scar, but the material as that's being broken down can lead to an inflammatory reaction, and it looks red along the wound margin. Mistakenly think that this is an infection. So this is where adequate counseling of the patients is important. We can also manipulate patients' genetic material to combat certain infections. This is not something that's commonplace, but these are areas are being studied, so that in the future diseases can be at the same time able to. Those are areas that are currently under investigation. Following COVID, a lot of patients' surgery got delayed, and at the moment here in the UK, we have quite a round of doctor strikes for pay, and all of these impact on patients' waiting times for surgery. And so patients are there in pain, and it's important as clinicians that we try and make sure that they're as comfortable as possible whilst they're awaiting a surgical procedure.
Should I give you one?
Please. So in terms of pain control, this is where the part of the optimization comes in from the patient's general practitioner. And we can also recommend things such as a TENS, which is a transepidermal nerve stimulator, a machine that gives us a little pulse on the skin, which is something that helps with management of pain. So these are things that can be used. Injections can be used, but they should be done judiciously. The injections available are local anesthetic and steroid, hyaluronic acid, platelet-rich plasma. That's basically someone's blood is taken, it's centrifuged, the red cells are removed, and what's left is a plasma. And in that plasma are stem cells, which have the potential to become any other cell in the body. And when you inject it into the knee joint, the surrounding cartilage sends a signal to say, look, I want you to become a cartilage cell. You can never replace the cartilage that you were born with. A different type of cartilage is laid down, but it's better than having bare bone. So these are things that can be used. Now, in patients that have advanced arthritis, it's not really beneficial. In fact, local anesthetic, hyaluronic, and platelet-rich plasma are unpredictable in their outcomes. But it's something that's worth considering if simple analgesia, modification of activity, weight loss, and physiotherapy on their own have not been beneficial. There's an injection that's come on the market, it's recently been licensed here and in the US, called arthrosamid. It's a polychromide gel that's for use, currently licensed only for use in the knees, but I'm hopeful it will be extended to other joints in the future. And whilst it doesn't change the wear of the cartilage on the bone, what it does is coat the lining of the knee called the synovium, which becomes very inflamed during arthritis. And by coating that and dampening down the inflammation, patients experience less pain and are able to move more. And so it's a way of managing arthritic pain and may be useful in patients who are not well enough to undergo surgery or not quite ready for surgery. The benefits have been said to be up to 3 years, though there are some studies that show benefit extending as long as 7 years. But time will tell. As I said, it's something that's very new to the market. The gel by itself, even though it sounds excellent, with all these long-term benefits, is not for use in isolation. You can't do that without addressing the other things, such as the weight loss. What happened there? Such as weight loss, the physio exercise, etc., is all done in adjunct to the injection. And things such as knee are very, very beneficial in trying to keep patients as mobile as possible and to reduce the forces going through the joint, which would then ultimately lead to pain. Here in the UK, there are organizations that can help patients deal with the psychological aspects of pain, because when patients are in pain, it does impact their well-being and their general outlook, and it affects them psychologically. They can become very depressed, withdrawn, in fact, particularly if their pain is such that they're not able to mobilize outdoors, they become isolated at home and so on. And so it's important that they are directed into the right areas to get the support that they need. So, if you're lucky enough to have extended family support and so on, then that's fine. But a lot of people are actually living alone, and so they need help. And in England, we have organizations such as Arthritis Action versus Arthritis, the Samaritans. I'm not aware of what's available in all parts of the world, but for those who are dealing with patients, I would recommend that you educate yourself with regards to these organizations and point the patient in the appropriate direction. Because of our long waiting times in the NHS, a lot of the private hospitals here are offering self-pay packages for patients who are not insured. I have formed an app, which I've done in collaboration with Patient Journey app. And it's free to download from the App Store. So you have to go to the Patient Journey app, and then the healthcare provider is joint replacement surgery. So there are lots of different apps within that body, but mine is the joint replacement surgery app. And on there, it gives all the information regards joint replacement. It has videos on there of exercises that patients can familiarize themselves with prior to surgery, so that after surgery they know exactly what it is that they need to do, and they can get on with it safely. And all questions in terms of risks and so on, the type of anesthetic, etc. That's all on that app. So one of the other techniques that we are advancing right now is our surgical technique. And I stress to you the importance of an adequate surgical technique. It's for, number one, less soft tissue damage, which will lead to reduced risk of infection and postoperative pain. It's about implanting the implant in a suitable way to mimic the patient's known anatomy, and that will lead to a long-term outcome of the implant and also hopefully better function as well as pain. And minimally invasive techniques means less muscle dissection, which again would lead to less pain, less weakness, and early recovery. So the techniques available are computer-assisted robotic surgery, as well as minimally invasive techniques. And there are lots of different robots on the market. These are some of the ones that I use. I have found that the robotic surgery is more useful for knee implants, for knee replacements.
I don't know.
Than
I've been outside since. You can.
Sorry, can we mute, please? Increase your accuracy and reproducibility in terms of surgery. At the moment, there are clearly defined outcomes, improved outcomes using the robotic surgery over the conventional type of replacement. But in terms of a functional outcome, we find that those who had robotic surgery recover faster, but by conventional surgery, one catches up within 3 months, in some cases by 8 weeks. And so at the moment, there doesn't appear to be, because when you have to balance that against the cost of doing the surgery, at the moment, I can't hand on heart say that the studies, whilst we can demonstrate improved accuracy of implanting the components and alignment of the prostheses, what we need to wait and see is the long-term benefit. And there's no doubt that if you put an implant that closely matches a patient's anatomy, I think that it will ultimately give better long-term function, but the data is not yet there. But I can show you some of the improvements that we have noted. And that's me doing a robotic knee replacement procedure there. And so when you're doing the operation, what happens is you have some stereotactic pins, which are here, and there's some lower ones here, which this computer here tracks and picks up, so it tells where the joint is in space. And then on the computer screen, there's a map. You have to collect data from the knee, which it's on the computer. And from that, you can program in where you think the implant should lie. And then there's feedback that you get here that you can see on the screen as to how much bone you're taking off. And so it helps you take off just a precise amount of bone. Now, this system is what we call a computer navigated system. And the difference between this and a robotic system is that with a new navigated system, you've got to keep an eye on the screen, and it changes color from purple to white is what you want to be at. If it goes into the red zone, that means you're taking off too much bone. With a robotic system, it actually stops you. The machine will actually cut out and stop you taking the excess bone that you don't want to. So that's just the difference in the two systems. So here is a paper. It's actually colleagues of mine at my hospital that contributed to this study, where they looked at robotic assisted versus the conventional knee replacement. And what they found was On this graph here, they're looking at the joint line, so the native joint line of the patient. When you put in an implant, depending on how much bone you resect, you can sometimes alter the joint line, and that has an impact because if the joint line changes in relation to the patient's kneecap, that can lead to some restriction in motion of the kneecap. Some stiffness may lead to patients requiring manipulation of the knee postoperatively, and increased forces go across the kneecap, which can then lead to pain. And so we want to try and get the joint line back to normal as much as possible. And with the navigated system, 0 is where you want to be at. With the navigated system, you're closer to 0 than you are with the conventional knee replacement. And then there's another thing that we looked at in this paper was the slope of the implant, the posterior aspect of the implant in relation to the back of the knee. And we saw that again, using the computer navigated system, it was closer than compared to if someone was using a conventional knee replacement. I mean, this study unfortunately didn't do any pain scores or functional outcome scores to see if this made a difference clinically to patients. But intuitively, it seems intuitive to me that if you put things closer to normal, then patients will get better. But there are a lot of studies out there, some that show that the navigated system does not make a significant difference in terms of changing the joint line. There are studies that show that the navigated system improves the mechanical access of the knee and improve component alignment. And there are lots of data out there that actually show what was the word I'm looking for? It's escaped me now. There's data to support that you're getting better alignment of the knee. As I said to you, at the moment, in terms of clinical outcome, we're not seeing the benefit proven significantly. But I think that's only because the robotic system has been used in the short term. I still believe that it has a significant role to play, and that in time we will see that these prostheses are actually lasting a lot longer. Now, what have we shown on the hip side? We've shown that we have predetermined criteria for accuracy of placement of components. And the area of accuracy where we try to place the implant is defined in this oblong here. And we've actually further increased the accuracy by making the area a smaller area. Now, we then compare the patients who have used the conventional hip replacement, which is this on the left, compared to those using the robotic system. And you can see that even in the conventional hip replacement, if you are a well-experienced surgeon, the majority of them are able to place the component in this safe zone. But you notice there are quite a few outliers outside of the safe zone. Okay, and with this conventional hip replacement, when you have the largest zone of accuracy, we get 80% of surgeons getting in there. But when you reduce the zone of accuracy, it reduces to only about 60%. However, about 90 plus percent get within the very high safety, reduced margin of safety when you use a robotic implant. So we know that using a robotic system increases our accuracy. And as I said, time will tell whether that leads to improved outcome of the implants. Now, it's not just about getting the component into that area of safety, because you can place an implant, an acetabular component in that area of safety and still dislocate. So as a surgeon, we have to consider other factors such as the patient's spine, if there's any spinal pathology. Because if the spine is stiff due to arthritis, it doesn't change its position as the patient sits down, which doesn't allow the acetabulum, the pelvis, to clear the femoral head. And so there can be impingement between the femur and the acetabulum, which can lead to dislocation. So it's not just about looking at the hip in isolation. One has to look at the patient's spine as well. By using the robotic system, it also tells us where to accurately cut the patient's femur before we place the implant, which will reduce things such as a leg length discrepancy. We keep modifying our choice of implants available to see if that would improve our outcomes. one point, they were gender-specific implants because the anatomy of the female is different to the male in terms of the AP and medial lateral diameter of the femur and tibia. And so when you use a single implant off the shelf, you can't always adequately place it on the female's bone. And if the prosthesis is extending beyond the bone, then there's a risk of impingement of the soft tissues, which can lead to symptoms. However, this seems to, is not really taken off. What companies have done instead is to increase the in-between sizes of the components to try and cover for women. And the reason for that being is that if you have a female-specific implant and you have a case listed for surgery, and then the patient is cancelled for whatever reason, you may not have an adequate set available if you have to draft another patient who may be male. But by having one particular implant with various different sizes, then that covers all eventualities. Prostheses, when you do a knee replacement, we often sacrifice the anterior cruciate ligament. It's surgeon preference as to whether they substitute the posterior cruciate ligament if it hasn't already been damaged. And it all just depends on the surgeon's philosophy. They were looking at implants where neither ligament was spared, but again, that's not something that's taken off because without sacrificing at least one ligament, it makes access into the cavity to resect the bone ready for surgery very difficult. Implants are now more mattering of the shape of the patient's femur, so it's more anatomical in shape. We're looking at things such as a dual mobility hip, which I'll show you in a moment, where instead of a standard ball in a socket for the hip replacement, you have a ball inside a ball. And the reason for that is that it allows you to get a larger head, more matching of the patient's normal head, and that reduces the risk of dislocation. That was really the thinking behind the hip resurfacing, but there was some problems with the hip resurfacing because of the metal ions. It was a metal against a metal prosthesis, and the metal ions were leading to there's a risk of carcinogenic problems with it. There was a concern with that because chromosomal abnormalities were noted, although nobody actually developed cancer, but that was a concern. And also because of the stiffness of the metal in relation to the bone, there was some stress shielding and there was some wasting of the bone below the neck of the resurfacing prosthesis, which was leading to fractures. And so the way of using a dual mobility, I'll show you that in a minute, is to use a standard hip replacement, but on top of the normal small ball, then you put a larger ball on top of that. Implants have different modularity in order to match patient's anatomy. And what's coming in the future is something called smart implants. Now, what does that mean? It has a microchip in the implant. And so that implant will be able to detect things such as a change in the pH. Now, when there's infection, the pH drops and it'll be able to detect infection before a patient develops any clinical symptoms. In that way, there's an increased chance of being able to salvage the prosthesis because you can institute treatment early. The smart implants will also be able to detect micro movement and in that way be able to pick up any loosening of the prosthesis again before there's any significant consequences. So in terms of our materials, and I need to keep an eye on the time here. In terms of the materials, we use metals, polyethylene, and ceramic for our hip replacement. And the metals, we are constantly looking at metals because we want the metals to closely relate to the patient's bony elasticity. So the muscles have to be tough, they have to have a resistance to wear, they must have a modulus of elasticity close to bone. They must, when they cause debris, and inevitably there will be debris formed. We want to make sure that it's something that causes minimal amount of debris, and also the size of the debris needs to be such that it's easy to be engulfed and removed by the body. Porosity is important, particularly if you're looking at an uncemented implant. Now, prostheses can be put in with or without cement, and if you're not using cement in order to stabilize the implant, then you're going to be using a prosthesis where bone can grow onto it. And by it being porous, the bone can be incorporated into the prosthesis, which can then lead to excellent fixation and less chance of loosening. So this a quick diagram to show you some of the implants. This here is a fully cemented implant. The prostheses that are cemented have a different shape. They have more of a taper, allowing it to sink within a cement mantle to get stability. And then the plastic has ridges on it where the cement can adhere to it. And also then you make a provision by making little holes as well into the bone so they can also fix and get great fixation. This is a what we call a hip resurfacing, where you on this picture you see you cut less bone. When you are doing a standard hip replacement, the bone cut is further down. Now under here as well, the bone is not cut all the way. The bone actually goes all the way up inside this prosthesis. So you're just really taking off the surface. Hence, it's called a hip resurfacing. But in a conventional hip replacement, the cut is made further down, so you take away less bone. But it's not a minimally invasive procedure. In order to be able to expose the bone to just remove the surface cap, you actually have to make more of a muscle release. And so it's not a minimally invasive procedure. People need to be aware of that. But because they were having problems due to the stiffness of this metal in relation to the bone, with subsequent narrowing of the bone beneath and fractures, they're now looking at a new implant where the prosthesis is made of a plastic. But it has a titanium metal coating on it to just reduce the wear rates. So this is something that's newly come onto the market, and we'll wait to see whether this gives better long-term results. This is the bipolar hip I was talking about, where you have a standard head that goes on top of the femoral stem, and then on top of that goes a larger head, which then moves inside the cup. And so you're getting the benefits of a larger head, reducing the risk of dislocation, but you don't have the metal on metal articulation because the metal debris can lead to chromosomal abnormalities. In terms of modularity, patients' shape of their femurs are different, and so you can have implants that closely match that. There is concern, however, because the more modular the prostheses, there's an increased region of potential failure of the implant, and you can get a movement between the stem and the neck of the prosthesis, which again is a potential for release of metal debris. So whilst we may gain an advantage in terms of modularity, there is that risk as well of generating metal debris. In terms of the bearing surface, the most important part of the hip replacement, you've got ceramic on ceramic. Now, ceramic is the best material we've got. It's tough. There's less debris generated. We tend to use it more in younger patients. Whilst it has those good wear properties, it's a very brittle structure. And so if you fall and fracture it, the fragments can cause quite a lot of problems because it's very difficult to detect it. And it's so hard that if you put another implant in there, it can actually wear it away. So, we care in elderly patients because they may fall, there's a risk of fracture. It is more expensive as well. And, if you're very elderly, then you perhaps do not need as much, the prosthesis is not going to be there as long a period of time to generate as much wear debris. In an older patient, we tend to use a metal on polyethylene. Not metal on metal, but the metal on poly, which is slightly inferior, but not significantly so, because the plastic has been toughened to reduce its wear, and the gosh, I don't know what's happening with my brain today. But the matching of the two components is such a way, so closely matched that reduces the friction and therefore the wear. This here is a special type of implant which we tend to use if someone has significant bone loss and is more commonly used in revision surgery rather than the primary. And it just gives extra ways in which to fix the prosthesis onto the bone. With the polyethylene, from the time a hip replacement was first used to now, there are ways that we have significantly improved the polyethylene by cross-linking the bonds in the material, which leads to strengthening of it and reduced wear. The techniques that we use to sterilize it and so on as well are used to not weaken those bonds. And by treating it with vitamin D and gamma radiation, etc., we can also lead to significant bond formation that helps to strengthen the prosthesis. Now, that might be a distressing slide for some people, I won't stay too long on that, but basically this is a ceramic on ceramic implant. The lining of the cup is ceramic, the head is ceramic, but we're moving away from that because ceramic on ceramic, whilst the best bearing surface that we've got, can lead to squeaking. And the squeaking can be quite unpleasant. So we have moved away from that. In terms of knee implants, we resurface the femur, so the worn cartilage and bone is removed and the prosthesis is put in place. On the tibial side, and that's made of metal. There's a metal prosthesis as well, which is fixed inside the bone. Prosthesis can be fixed with or without cement. And then on top of that is a plastic lining that's normally it's fixed to the tibial component so that you have metal on poly bearing rather than metal on metal. And this can be minimally constrained or constrained depending on whether you're trying to counter the loss of both the anterior and posterior cruciate ligaments or whether the patients have the collateral ligaments in place. It's very important that there is stability of the knee and that you are able to balance the ligaments on both sides of the knee to make sure that the forces are equally going through the knee replacement and there's no abnormal wear. So on this replacement, you can see here, this plastic here is smooth. Here there's a peg. If the patient has lost the posterior cruciate ligament or it's the surgeon's philosophy to remove the posterior cruciate ligament, then we have that peg in place. Sometimes patients' arthritis is very located into just one area of the bone, in which case one can then do a partial joint replacement. And that can be of the femur and the tibia or replacement of just the back of the kneecap and the front of the femur. The shapes of the material I talked about, making them more anatomical, and the medial condyle tends to be larger than the lateral. It tends to be larger in the AP diameter, whereas on the lateral condyle, it tends to be wider. And so, implants have now been modified to match that, whereas before it was symmetrical on both sides. And that is showing to have good benefit. Orthobiologics are substances that are normally found in the body that can be used to treat conditions in the body. Things such as platelet-rich plasma, which I've mentioned earlier, using cartilage cells. So you take patients' cartilage from the body, grow the cells in the laboratory, and then re-implant them into the patient. And they can be used in not only just treating bony conditions, but for ligament injuries as well as muscle injuries. However, I think the data is unpredictable, but in certain conditions such as tendonitis around the elbow, I know a lot of my upper limb colleagues have noticed significant benefit. Also used for conditions such as Achilles tendonitis. So these are some of the treatments that we use in adjunct to all the surgical techniques. So what are the orthobiologics available? Bone morphogenic protein, platelet-rich plasma, the chondrocytes where I talked about growing in the lab. A mosaic plasty is where you take a plug of bone. It's a bit like doing an apple core. So you have a plug of bone with some cartilage on the surface, and then you'd make a receiving area where you drill an area that the plug can then go in. So you're moving cartilage from an area where it's not on a weight-bearing surface or not in the articulating surface and planting it into the area where weight-bearing is taking place. These are some of the techniques that we use. So one of the other advances in joint replacement is reducing infection, preventing infection. And we do that by having meticulous technique. And it's things like being very careful when you're in the operating theater. When I am prepping the patient, I change my gloves before I actually start the operation. And I make sure that my cleanest gloves are on before I put on the light handles, for example, because the light handles are going to be used throughout the operation. Throughout the operation. So you don't want to have touched that with gloves where you've been prepping the patient. And then the surgeon, even if they put on clean gloves, will be touching that afterwards. So just paying attention to simple things like that. Before implanting the prosthesis as well, I take off the gloves I've been operating with and put on a fresh pair of gloves before I handle the implant. You got to take care to the number of people that are in the theater because people are skin cells and different things that are being released all the time, and just that shedding of cells and just it changes the airflow as well in the operating theater. That can lead to more dissemination of bacteria in the operative field. So reducing the amount of people in theater, that sort of thing is very important. In addition to the way that you're handling the tissues, if you're traumatizing the tissue, it's more likely to become infected as well. One needs to be speedier with their operating times. And for patients who are prone to have infection, one can enhance their immune system, possibly by vaccines or giving them an organism that has been treated such to reduce its infective capacity, but is still producing proteins that can be recognized in the body to which they can form antibodies. And most of the work that's currently taking place is on eradication of the biofilm. The biofilm is like a shield that the bacteria has over it. And so when you give antibiotics, it has this shield which the antibiotics cannot penetrate. And that's why the infection persists and is difficult to treat. And if we can find ways of destroying the biofilm such that antibodies can penetrate, then it's less likely that when a patient has a joint infection, we will have to remove the whole component. We'll be able to do much more salvage techniques. So that's an area where a lot of work is being taken place at the moment. So how do we detect infection? It's important you take a history. If the patient has a history of a wound dehiscence after the operation, then you have to think about infection. If there's redness and increasing redness and pain and swelling, then one has to think about infection. And then there are tests that we can do. You can look at inflammatory markers. You have to be careful because immediately after surgery, the markers are raised. So one has to look at a trend. We can take fluid from the joint. If you're going to take fluid from a joint replacement, it should always be carried out in a sterile environment, because the last thing you want to do is actually introduce infection whilst you're trying to do a test on a patient. We don't really use leukocyte esterase reagent strips. Those are the ones that you get where you can test for urine infections, which you dip into the urine. You can take a specimen from the joint fluid and put that on these strips, but they often have debris such as bits of bone and blood, and that can confound your test. So we tend to use serum biomarkers. These are substances that are normally found on the bacteria, which we can detect, and then that will give us an idea as to whether there's an infection present. But of course, if you see things clinically like pus, etc., then that's obvious. But sometimes it's not so clear whether there's an infection, and we need to check this. If you can, in this time, you take a specimen from the joint, you send it off to the laboratory, and you wait for them to grow cultures. But in patients where you may want to do an urgent implantation, so you take out a prosthesis, and before you want to reimplant on the same sitting, it's important to check with these biomarkers, which gives you an instant result as to whether there's an infection present. Postoperative optimization involves education of the patient, which starts preoperatively. If patient know what to expect, what the outcome is likely, then if they explain to them that there may be some pain in the initial period which will get better, then they're not so anxious and concerned. So it's about educating the patient, letting them know exactly what they need to do to take care of themselves and to get the best out of the implant. We want to make sure they have adequate analgesia. And when I'm operating, I inject anesthetic, which a combination of anesthetic, steroids, anti-inflammatories into the patient's joint, right from the bone up towards the skin. And by doing that, it really improves their requirement for opioid painkillers afterwards, because opioids can make them feel sick. It can make them feel drowsy. They may fall over, etc. So we want to reduce the amount of opioids that are required. There are also studies that show that the use of duloxetine, which is
I'm just coming back,
an antidepressant, which also has good benefits and it improves the patient's mood, and it's been shown they require less opioids post-surgery. And that's something that's usually started either the day before surgery or on the day of surgery and continues for 2 weeks. Post-operatively, I make sure the patients have adequate analgesia on board, oral, intravenous, oral as well as intravenous, and they're given it regularly. And there's also an option for them to have adequate extra painkillers if they think it necessary. And we make sure that when we discharge patients, they discharge with satisfactory analgesia. The important thing is to really get on top of the pain so the patients can improve their confidence. They can then mobilize adequately whilst in hospital, and that gives them the confidence when they get home. We are now moving towards day case joint replacement surgery. And so we have to work very closely with our anesthetists to ensure that the pain control is adequate. This is a patient who just, 30 hours after surgery is already bending the knee quite well, and also can just start to lift the heel up off the floor. So already starting to initiate the quads. And the only reason they can do that is because they've got adequate pain control on board. Postoperatively, though, we don't want the patients to become reliant on the strong painkillers. We try and decrease the opioids certainly as quickly as possible, but keep them still on a satisfactory regimen. We want to make sure they take the analgesia regularly. Some patients believe because they're not in pain, then there's no need to take the painkiller. And the education is to let them know that they've got to maintain it in the system at a certain level, and that means taking it regularly, even though they may not be in pain. Ice packs are an important adjunct, as well as the use of a TENS machine. So what other advances have we got? Well, 3D printing, where we can actually capture data of the patient's anatomy, and then from that, we can print a prosthesis that is individualized to the patient. And as mentioned before, by individualizing the prosthesis, this can lead to better alignment of the prosthesis, less dissection required in order to implant the prosthesis, recreation of the normal forces is closer to the patient's normal anatomy, which will ultimately lead to less pain and better long-term function. That's the hope. It's a very expensive process, and really at the moment, probably just used for patients who have significantly abnormal anatomy. I don't think there's enough data to suggest that everybody needs to have that. Smart implants I've already touched on. Coating the implants with silver. Now, silver has been shown to have a bactericidal effect, so that may be something that comes in the future, is using more use of silver in the implants to reduce the risk of infection. And then we now have the virtual augmented reality. And this is what we're now using to train our surgeons. They can actually go through the steps of the operation prior to being released on an actual patient. So it's better for the surgeons to teach them so that they get their practice in that setting prior to actually operating on a patient. And it's been proven to be very useful and very exciting. Thank you very much. I hope that I've stimulated you enough to have lots and lots of questions, and I look forward to the debate.
Thank you so much, Ms. Samantha, for the wonderful presentation.
My pleasure.
Okay. If you have any question, please can you use the chat button for your question. Before that, there is a question in the chat button. The question from Get Myers. The question says, what are your thoughts about the scrub style, wearing the orthopedic hoods that cover the entire head and enclosed by the gown as a way to reduce the SSI potential? This is common practice in the US.
Yes. Well, like I have used that in the past, and I found it very difficult for the staff to hear me when I'm giving instructions. And when I carried out a study of my patients in my practice, there was no significant benefit in terms of infection. My infection rates are less than 1% anyway. And so because of that, I have discontinued using it. But it has its place, and if you're in an environment where there's a potential risk of infection, then I think every technique should be used to try and minimize that. There is a different hooded cover that's supposed to make it better for people to hear you. But we ordered that in my hospital, and it was just prior to COVID, it never arrived. And so I stick to my conventional, but I pay very close attention to the other areas in which I can reduce infection.
Okay, thank you so much for the answer. Is there any other question?
We've got Gert Mays with their hand up. Gert, would you like to ask a question?
Thank you. I was just giving you a thumbs up. I appreciated your answer about the hoods.
Okay, thank you.
I think I have a question. That was a brilliant presentation, Dr. Samantha. Thank you so much for that. I think it was very detailed and very insightful as well. Well, for me personally, I think I've been in orthopedics now for like a couple of years, and I've seen a lot in this. Like I've seen both sides, both African settings and the advanced ones. Sometimes in terms of the infection prevention and control, I've seen that some surgeons actually now they started using the Viden irrigation, and they started using the pulsed lavage as well for infection prevention and control. Do you want to talk a bit more about that so that we can actually understand why we need to use that, or if it's just their preference? Or
so I heard the pulse lavage. What did you say prior to that?
The Viden, you know, the betadine irrigation, Viden.
You're right. Oh, yes, right. Okay. Look, I think if you're in a setting, it's important to do regular audits.
Yes.
To know what your infection rates are. And then every step must be taken to minimize that. And if that requires you to wash out the wound with iodine, I mean, I don't personally do any of these things, but you know, I continue to monitor my rate of infection. As I said, it's less than 1%, and it's maintained that way. But these are extra steps that one can take, and I think in the setting where there's a risk of infection, it should be used. I always use pulse lavage, because dilution is a solution to pollution. So, you know, we give the wound a thorough washout. It's washed out before implanting the implant. So yes, I use a lot of, I use the pulse lavage. I don't personally wash with ID, but some of my colleagues do. You know, so in my hospital, you know, we don't all have a standard technique, but each surgeon has their responsibility to keep an eye on their infection rate and to do whatever is necessary. So regular audit is the key.
Yeah, thank you so much for that. Yeah, exactly. The evidence first, and then they can decide if they want to use Viden irrigation or not. And at the same time as well, you mentioned something in relation to, let me see if I have it down, in relation to balancing the knee, especially in the knee replacement. They do the femoral resection and then the tibia resection. And you mentioned something that regardless of the approach of the knee replacement you're doing, one of the ligaments needs to be sacrificed, and that would be the anterior cruciate ligament. But I've seen some people or some surgeons now, regardless of that, they always take off the PCL. Would you recommend that to balance the knee, they sacrifice the posterior cruciate ligament as well? Would that be the standard or just the preference of that surgeon?
It depends on if there is a significant deformity of the knee, such as severe valgus in particular, then I release the PCL, because it's difficult to get it balanced otherwise. If a patient is common, they haven't got significant deformity, I try to preserve the posterior cruciate ligament. But there are some of my colleagues who believe that in the presence of arthritis, the posterior cruciate ligament is not performing normally. And therefore, that's why they release. And I think it's all to do with your own philosophy. For me, if I can preserve a patient's anatomy as much as possible, I try to do that. But in case of severe deformity, in order to balance, I have to sacrifice the posterior cruciate ligament.
Yeah. That's it. Thank you so much for that. And just one more. You mentioned as a preference, personally, you prefer to use clips, skin clips?
No, I don't. I prefer to stitch the wound.
Okay, stitch the wound. Okay, I thought I heard clips. And in relation to patient allergies, how would that affect the choice of implants or the choice of closure of the patient, the wound closure or implants in terms of allergies? patient allergies.
Yes, well, yes. So that's part of the history taking. That's part of the pre-op workup for the patient. Now some patients don't know they have an allergy. You don't know it until you've done the operation, and that's unfortunate. But you ask patients for any evidence of nickel sensitivity and so on. Because we know of these allergies, a lot of the implants now, they've minimized the use of nickel and so on, the common things that people are allergic to. Okay, but if someone has known to have an allergy, then we use a ceramic coated implant. Because you can't just use, for instance, in a knee replacement, a completely ceramic prosthesis because it's very brittle. There's a risk of it fracturing. But if it's just coating on the surface, then that can be used. And so that's what we would use in those patients.
Thank you so much. Yeah, that's it. Thank you. Thanks, really.
My pleasure.
I think there are some questions, a few questions in the chat box as well.
Oh, I can't see if someone tell me what they are.
Okay, someone is asking, do you think wearing non-powdered gloves in handling implants makes any difference in possibility of introducing infection? Powdered or non-powdered?
Well, I don't use powdered gloves, so I can't talk. I don't know. But I would have thought that you don't want to have any potential other debris on the implant. I would have thought that perhaps non-powdered, but I don't have the evidence.
Okay, yeah, I think there has to be more research in relation to that to actually know if powdered gloves have any effect. And then someone else is asking, what would you say about the use of ChloraPrep instead of the povidone iodine for the skin prep, for the prep?
Yeah, again, I think surgeon preference. Even with the betadine, some people use pure betadine, that's me, aqueous betadine. Some use betadine plus alcohol mixture. Some use the chlorhexidine. The chlorhexidine is clear though, and it can either be sort of like a light pink. When you put it on the skin, you can't always see that you're completely covered. And that's why I actually like using the betadine, because when it's on, you can see which areas haven't been adequately.
Exactly.
But some of my colleagues put on betadine and then put chlorhexidine on afterwards. I don't understand that. I stick with one. I use aqueous betadine.
Yeah, makes sense. Thank you so much. And there's one more question as well. How do you see the durability of the metallic hardware? That's the implant, the metal. Now, the metal implant, is that durable or?
Well, it is. I mean, it's been proven. I mean, we've been using it for years. It's just that they are the metal itself doesn't tend to fail. When an implant fails, the failure.
This one is the first female orthosurgeon.
Oh, someone, can you just mute your microphone, yourself? Sorry for that.
Lydia having a big conversation. Lydia, who are you talking to? Oh, there she goes. Right. So when the implant fails, it's not usually the metal. You don't get metal fracture or break. It's usually a debonding between the prosthesis and the cement, or the cement and the bone. So the metal is durable, but there are problems in terms of the wearing, in terms of the wear particles that are generated. And also the stiffness of the metal in relation to the stiffness of bone, and so that discrepancy can lead to problems, fractures due to osteoporosis or stress remodeling at the interface between the prosthesis and the bone, and so that's where the problems lie. But the metal is durable.
Thank you so much. I hope that
some metals are tougher than others. So something like titanium closely matches the elasticity of bone, but it's not tough enough and will be more worn. So you can put that in certain areas, but not where it's actually doing most of the work. So those are the things we need to look at.
Okay, thank you. I think one person is also asking, that's for perioperative nurses, what are some techniques that can help with the overall outcome during such procedures? Maybe techniques for the scrub nurse, for your own scrub.
Well, I can't stress enough how important it is for the scrub nurse to really feel part of the operation and to be following the steps as the surgeon is operating and almost be thinking ahead so you can pass the adequate equipment. And by doing that, it streamlines the process, makes it a lot faster. That means the wound is open for less time. and so there's an reduced risk of infection. Getting the right equipment ready. Often, we have a brief before theater, and I'll say, look, this is what I need for this particular case. And then I come to that point in the operation, I need it, and then someone has to go running to look for it. That's not ideal. So we really need the scrub nurse to be present, i.e., not just there, but present, really taking responsibility, making sure the equipment's there, relaying the information to the surgeon as to what implants may not or may not be available, not waiting time when it's called for to say, and as I said, following the operation, and also being confident enough to speak up. You're a valuable member of the team. And if you see something being done that's not standard, then to have the confidence. And I think as surgeons, we need to create that environment where people feel empowered to be able to speak up.
Thank you so much. Thanks a million. Any more questions? I think all the questions have been answered. There is someone saying—
Is there a benefit to closing with clips rather than stitching? It's faster. I mean, and that's why in the hospitals they're pushing for us to do that, because they want to just push through as many patients as possible. But I personally, it can be very uncomfortable for the patient to come out. Some people may have metal sensitivity. Often, when people are using clips, they're not taking time to actually stitch, and they're using expecting the clip to do the work of holding the wound together. And I don't think that's right. And so that's the problem, I think, with clips. It just leads to shortcuts. But done well, I think a clip can give a nice scar. But often what happens is, because people want to save time, they don't close the wound adequately. And they're trying to rely on the clips to hold the wound together. And that's not great. Because there's a lot, what happens then is the tissues are the traction of the tissues are pulling on the clips. And that's what leads to the horrible scarring.
That's true. Thank you so much for that. I think all the questions have been answered. Let me see. So there's someone saying that was a brilliant presentation. Thank you, ma'am. Someone saying that was a detailed and insightful presentation. Lots of positive feedbacks in the chat box. So thank you so much, Dr.
My
Samantha.
pleasure.
Thanks for honoring our invitation. I believe we've learned a lot tonight, especially in terms of the advancement, smart implants. You mentioned that has a microchip detection to detect infection and micro movement, just to prevent any mishap ahead of time. That is really brilliant, and we would really love to see something like that. And then at the same time, you mentioned the choice of implants, gender specific. You wouldn't want to use one implant for both male and female, which is really good to know. And then the anatomy of the patient as well is a great determinant in the choice of implants. Patients who have very valgus knees, varus knees, and more. And then you mentioned the cement, especially cement and uncemented technique, and which is really what we want to know about as well. I think the topic is way, way, way too broad. We might bring it back to continue this if that is okay with you. And then we have the session recorded. With your permission, we can share that across our platforms if it's okay with you. And
yeah, that's fine.
If anyone wants to reach out after the session as well, we can share your details if you don't mind, especially organizations that might want to bring you back on their platforms just to speak to their members as well, if that is okay with you. So thank you so much for honoring our invitation. Thank you for sharing relevant knowledge. We've learned a lot tonight, and I believe we're going to build upon the details we've learned and leverage upon that and improve the outcomes in our hospitals. And thank you everyone for connecting. Good morning, good evening, good afternoon, good evening, and good night, depending on your time zones. Thank you so much for taking the time out of no time to join us in this session. And in another 2 weeks, we're going to have another session on gynecology. And thank you so much, everyone. I want to say thank you to the education and training team for bringing together this brilliant presentation. Thank you so much, everyone. And bye, 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 bye. Thank you.
Bye.
Bye.
Bye-bye. Bye.
Thank you so much.